My name is Santiago Camacho. I apologize to the first author because he couldn't come to tell us the case, and it's called "It's Really Lost." I have any potential conflict of interest, and I'm going to present you a 7-year-old male case with hypertension and type 2 diabetes mellitus. He was admitted with an anterior non-STEMI. And as you can see here, we have a single vessel stenosis in the mid-LAD, calcified, tortuosus, etc. A challenge lesion. Okay. So first of all, we underwent by radial approach with ABU 3.56F catheter, and we started with pre-dilatation with semi-compliant balloons, 2.5 by 20. Long balloon, as you can see here, scoring balloons, and we decided to implant two DES in the mid-LAD, 2.5 by 22 distally and 3.5 by 18 millimeters proximal. After that, distal dissection of the distal edge of the distal stent was showed. As you can see here, the arrow. So what that? We tried to cross another stent to solve the distal edge dissection, but was unsuccessfully. We tried it with catheter extension, body wire, several pre-dilatation in the proximal part with non-compliant balloons of 3 millimeters, and after that, you can see here, we couldn't cross it. So in this mess, we lose the wire, everything go out, and when we try to look at it again, we saw a radiopaque mark, as you can see here. So, and we suggest a loose stent, the proximal stent of the LED, as you can see here in the with the row. So, what's now? No? Well, I think you have several options. You don't have the wire inside the stent, so you can't use the small balloon to try to cross inside the loose stent. So we try to catch the stent with two wires, like taking like a small snare, and it fails. So the stent was still there. So at that moment, the operator decided to crash the stent. So he underwent with post-dilatations with non-compliant balloons to very high pressure. As you can see here, the mark is still there, the stent. And at the end, we decided to implant proximally another stent, a bigger one. But the distal stent was still there. Crash, but it was there. This is the final result. And after post-dilatation with several balloons, we decided to leave it like that because the patient was stable, so we decided to leave it like that. The patient was quite good. 3 years later, he was asymptomatic, but he was admitted in the hospital due to a typical chest pain. And we decided to perform him a treadmill exercise test and was clinically positive. So another angiogram was performed. As you can see here, you can see here, still there is the crash stent in the distal parts of the LED. So we decided to show it with intracoronary imaging technique. We decided to do a OCT. And as you can see here, this is the distal, this is the proximal part of the vessel. And in the number 1, we show the previous underspanned stent over there, a crash stent endothelized without severe hyperplasia on the distal segment of the LED. A bit more proximally, you can see the previously implanted stent on the middle segment without hyperplasia and the crash stent inside the distal edge. So this is the interesting thing of probably of the case, no? This image by OCT, which is not very common to see. In conclusion, I have to say that in case of stent loss during PCI, we have several options to solve we use two wires technique to catch it, snares, small balloon technique, crash it, or embolize it distally, etc. Intracoronary imaging technique may play a role in these situations and can help you to evaluate the final result to decide management in this case. In case of underspanned or crash stent, OCT can show you how is the endothelialization and if there is any complication in the follow-up. Thank you very much. Any question?
Initial strategy probably was one stent strategy, and I think I saw that diagonal branch was stenosed on the ostium approximately 90%. You didn't plan to open it or to change your strategy?
At that moment, with the stent loose and everything, 79 years old, male, we decided medical treatment probably could find for that.
But 3 years later, artery is also patient, and it means that your strategy was good.
Yeah, I think so.
Any comments from the floor? Any comments from the floor? Can you put your... Is it possible to go back to your images?
I'm sorry?
Is it possible to go back to your images?
Yeah.
I had some questions about your...
images here?
You know, yeah, right at the beginning, it seemed like the place where you thought there was an edge dissection that you were chasing. Again, you know, there's been this sort of angiographic ambiguity and making a definitive decision about is it edge dissection and should you put chase it with a stent. I think it's a second such case. So
you mean
your final result and your initial diagnostic result look very similar to me.
Yeah, you mean, sorry, this, right?
Yeah.
Yeah.
To show the final picture, it looks...
Yeah, we suspect that there was a distal edge dissection at that point.
Yeah, so again, you have the imaging modalities to you. How often would you put an OCT wire down there to actually confirm what it is you think you're looking at?
Yeah, probably here. I don't know, we have a very tortuous vessel with calcification, so I don't know, maybe after implantation, if you see that, but after stent implantation, probably we will decide to cover it by a small stent, you know. Maybe in other situations, when you have more depths, maybe you can select an intracoronary imaging technique to see that. But in this case, it was decided to stent in directly.
I don't know what
but it's an option, of course.
Doubtful dissection.
What's that?
Very doubtful dissection.
Yeah, it's okay. If there are any other comments from the floor? There was just, again, a little bit of ambiguity about it, and I think that's been a recurring theme for much of this. I suppose that's why the session is unexpected coronary complications. You know, we've been sitting here trying to figure out the mechanisms of what's been happening. So that's why the discussion you'd missed earlier, there was a very similar case earlier on about, you know, deciding was it edge dissection, what was the mechanism, and were there other tools that perhaps we could have used to help us differentiate the various possibilities.